We have seen some awful impressive results with the second generation of drug-eluting stents. How about a second generation of a TAVR device? I'd like to introduce you to Ian Meredith of Monash Medical Centre-Southern Health, Melbourne, and he is principal investigator and implanted the first devices in this particular study, which is the REPRISE II study. First off, tell me a little bit about the trial.
So the REPRISE II trial is a study of a new, as you say, second generation heart valve, and this second generation heart valve differs from the first generation is that it's designed to address some of these important issues that we've seen, like paravalvular leak and also repositionability. With the first generation valves, there's always a little leap of faith when you finally try to get the valve in the final resting position. There's the balloon dilatation may move the balloon slightly, or with the core valve releasing the valve might move the valve ever so slightly, and you don't end up with it in exactly the right position. This might lead, under some circumstances, to needing a second valve, what's so-called TAVI in TAVI, or indeed removing the valve under difficult circumstances to replace it with a new valve. Ectopic valve deployment, malpositioning, replaced new valve. So the second generation device has the ability to be restrained on the delivery catheter even when it's locked in its final position. So you don't release it until you know that it's in the exact right position. So you're in total control. So it's a very different concept. You have full retrievability and full repositionability. So you never have the feeling that what's it going to be like when I finally let it go, because you already know you've rested it and then you release it. And the other thing that it has an adaptive seal on the outside of the valve, so that the seal actually blocks up any paravalvular leak. So the likelihood of getting a paravalvular leak is about 1%, where we've seen paravalvular leaks of the moderate and severe nature up to 15% in earlier studies.
Now, how many people were enrolled in the REPRISE II trial?
So the REPRISE II trial is 120 patients. It's a second phase trial, and there'll be a large US IDE trial starting next year. 120 patients, 14 sites in Australia, Germany, UK and France. And those 120 patients, average age about 84.5 years, typical high-risk patients, STS 7.1, STS plus 11.1, typical sort of high-risk severe aortic stenosis with a very extensive documentation of their other frailties, things that are not normally captured within the STS score framework. The outcomes were very good. As I stated before, the aortic regurgitation paravalvular leak was a 1% risk of having moderate or severe. In fact, there were no patients who had severe paravalvular leak, and there was a 1% chance of having a moderate leak. Over 90% of the patients had nothing or trivial aortic regurgitation after the valve was deployed. Now, if you're using a valve to treat aortic stenosis, you would expect that it treats aortic stenosis successfully, and that was a snap. It did a great job there. We had the pressure gradient, mean gradient from 46 down to 11 millimetres of mercury sustained through 30 days. There was a 4% 30-day mortality in an old frail population. The STS would have predicted you had a 7%, so we were well below that. And based on the catheter design, we expected that there would be no transcatheter valve, intranscatheter valve, or malpositioning or ectopic positioning, or the need to replace the valve. And indeed that was the case. That was a big series of zeros. All of those events didn't occur. And that again is a testament to the design, where you only release the valve when you know that you've got it in the right position. So that's a huge step forward. The other thing is that there were no roll-ins in this study, no roll-ins. So your first ever experience was included in the trial. So to achieve 100% success with your first up experience at every site also is a reflection on the ability of the device to be positioned appropriately and your control over the release mechanism.
And the procedure itself is not any more complicated, apparently, and I take it doesn't take any more time to do it?
Yeah, no, that's exactly right. It doesn't take any longer to do the procedure, and it is no more complicated. It's just a different mechanism. So there are two types of heart valves currently. There's the balloon expandable heart valve, where you expand it with a balloon, and there's the self-expanding, constrained in a catheter. You take off the sheath and the unconstrained valve pops into its original form. This is different. This is a mechanical and manual expansion, so the valve is constrained within a frame, but as you unsheath the valve, there is a series of mandrels that drive the valve to a shorter distance in height and at the same time expand the valve. And because it's manual and it's mechanical and it's controlled, it's a bit like setting the minute hand on your watch. You wind it to where you want it. If you get it past the wrong point, you just wind it back. And there are just a series of simple mandrels that allow you to drive it. And the final mechanism that locks the valve is very much like a seat belt. It just clicks in and it locks together. And you can unlock it and lock it as many times as you like. And if it won't lock, it's usually because the valve size is wrong. And of course, that's a simple case of just winding it back into the sheath, taking it out and replacing it. Now that happens 6 times in 120 cases. Now normally if you got the valve wrong, you would need to put another valve inside the one you already have. Reintervention for valve dysfunction, which is the term that's often used in many early phase clinical trials, which means replacing the old valve with a new valve or actually putting a second valve inside a valve, occurs in about 6% of cases. But in the 6 cases that we had, we simply just wound it down, put a new valve in.
So REPRISE II is up next, and when do you think that'll launch?
So REPRISE II will start June, July next year in the US. That's global. It'll be US, Europe and Australia will be involved in that trial. And that'll be the first randomised head-to-head valve against valve study. So that will be the Lotus valve versus either Edwards Sapien or Edwards Sapien XT valves in a very large study population, high-risk patients.
Well, congratulations. It sounds like you've got a great device here, and I look forward to talking to you again down the line, Professor. For CardioSource World News, I'm Executive Editor Rick McGuire. Please see CSWN online for more of the coverage from TCT 13.